Thank you very much first for the invitation. And I'm talking now, and that fits very well with the previous talk, about the update of the European Code Against Cancer. But at the same time, this is also a challenge, because what I'm not presenting today is that I just step to my right here and put another poster with a new Code Against Cancer. But what I'm telling you today is the process of how we're updating the European Code Against Cancer. So the bad news is you don't have new recommendations at the end of the day. But the good news is that actually you can still come up with suggestions of what we should consider in the process, because we have just established the working groups beginning of this year, and now it will be a 2-year process to actually update the code. So as a start, a few figures. We have heard some of them already in the previous talks. I mean, we all know that cancer is a major disease and major cause of death. We are talking here about millions worldwide every year. And the important figure is that we think about 1/3 of all these cancers is actually preventable. And this, of course, is the whole issue about implementing prevention to avoid the disease. So it's not only that cancer is a fatal disease, it's not only a deadly disease, it's also usually related with a loss of life quality when you have cancer. And it's also big expense, so it's estimated to be more than $150 billion in medical expenses for the treatment of cancer. If you just look at Europe, then we are having about 2.5 million new cancer cases diagnosed in the 27 member states. So it's 1/5 of all the deaths in the European Union. And of course, the second most common death after cardiovascular disease. One comment about this 1/3 of cancers are preventable. We have to keep in mind that here actually it's two messages. One is that we know causes of cancer for about 1/3, so this is where we can implement prevention already. But it also should remind us that there's a lot of cancers for which we don't know the cause. And this is, of course, a message to research. And cancer is a variety of diseases, actually. And when we look at lung cancer, for example, we can virtually explain probably most of the lung cancer cases, mainly by tobacco, but also by occupational exposures to asbestos, to silica, or to radon exposure. But for other cancers, we don't know about the causes. So what can we recommend for leukemias, lymphomas, for brain cancer, for testicular cancer? So there's a lot of causes also to be detected in the future. And this is, of course, a message why something like the European Code Against Cancer has to be updated continuously to put the new knowledge that we achieve as scientists is put into practice. So this is just a picture of the current version of the European Code Against Cancer, and I think everybody in the audience knows it by heart, so I'm not going into detail here. Just the message, you can see it was published in 2003, this is 10 years ago, and this alone, I think, explains why the update is necessary. One comment, the code has two types of recommendations actually involved. One is recommendations that reduce the risk of getting cancer, so this is more primary prevention, like stop smoking, but also recommendations that actually do not avoid cancer. This is mainly the early detection of cancer, and this is, of course, meant to detect cancer at an early stage so that it becomes curable, so it's reducing the risk of dying from cancer, but would not prevent the cancer occurrence as such. So what is the European Code Against Cancer? We think it's a key prevention tool. This is, I think, was also endorsed in the previous talk. It's necessary to update it. It's necessary to use it, and this is where we need all your help. And I'm very happy that I can see that you published the European Code Against Cancer in all your material, and seeing all these posters here also. I mean, this is very good for us as scientists also to know that what we produce here is actually put into use, and it's not just an academic exercise we are doing. So why do we do the update now? The science is dynamic. We want to look at the new scientific evidence, see whether the recommendations still hold. We want to do a little bit improvement in communications. We want to check whether the communication we did so far was actually good. We heard the example already about the alcohol. Is this really the message we want to convey? This is very important. And of course, since the last update of the Cancer Code, we have 12 new member states, so we also have to look at their common exposures and see that they are all reflected in the current code. So what we do in the update, how is it being done? We try to see whether we confirm the existing recommendations We see whether there's new potential recommendations. And what will be a new aspect of the code is that we also want to recommend individual interventions, if there are any. So if we recommend stop smoking, then of course the individual might have the question, well, how do I do it? How do I stop smoking? And of course there's a lot of advertisement of how you can stop smoking, reaching from hypnotherapy to just stop. And here we also want to give some recommendations of what has been shown to be effective if you really want to put these recommendations into practice. So who's doing the update of the code? It's supported again by the European Commission, DG Sanko. The project is led by the International Agency for Research on Cancer, and we are WHO's Cancer Research Institution. And the actors is that the scientific secretariat is at IARC. We have a scientific committee that will review the code before it gets public. And this is mainly external experts who are the directors of the cancer institutions all over Europe. And we have the expert working groups who are doing the evaluation of the scientific evidence. So for the update, I think substantial changes compared to the previous version is, first of all, the update of the scientific evidence. Secondly, that we want to have a better focus on the target group, and this is the individual. So our new version of the European Code Against Cancer is not directly addressed to decision makers. So things like tax increases to decrease the smoking prevalence will not be part of this version of the code because it's directed to the individual. So a clearer focus is one of the, I think, one of the changes we are going to make. The next one is that the current version of the code, so to say, exists of two layers. One is the brief recommendations that you see here, 11 recommendations, and then comes the scientific justification. But there's a little bit of a gap between the two of it. And this is that some of the recommendations may actually raise a lot of questions. And these questions we want to address in a second layer, in a layer between the two, that we call public health messages. So when we recommend physical activity, the public health messages will explain what is physical activity, how much physical activity is needed to decrease your cancer risk. Avoid too much sun. What does too much sun mean? And is it the same for all individuals? So explanations of the exposure, specific messages to target groups. Why, for example, is it more important for children to be protected from the sun? And also this recommendation for individual interventions. This will be a completely new layer in the European Code Against Cancer. And this is, of course, also a major workload that we are dealing with in the future now. So this is the picture you have to keep in mind as an illustration. So our target group is really the European individual sitting at his desktop or iPad or iPhone or whatever, or reading the tweets from this meeting and having a question, what can I do myself to reduce my cancer risk? How do I lower my risk of getting cancer? And the recommendation should be clear about this. So we are talking about 3 layers now. The first layer will still be the actual code, still brief recommendations, so it's easy to remember in a hopefully clear language. We have a communication group established that helps us scientists to phrase it properly. Sometimes if we scientists explain even something very easy, it's still clear as mud. So we have some experts here to help us. The public health messages in the style of frequently asked questions, so specifications, definitions, what do we talk about? Synergies between risk factors will also be a new area, alcohol and smoking, for example. The target groups, young and elderly, for example, the urban myth that, well, I'm 60, why should I stop smoking? Do I still have any benefits? So also messages directly targeted to specific groups, and these interventions at the individual level and their effectiveness. This will be in the second layer. And the third layer, this will still be the scientific justification, published in the scientific way, in scientific journals, so it's peer-reviewed, because you all know we are dealing with some powerful industries here that will scrutinize every statement we make. So we have to be straight about the science, and this will all be peer-reviewed and published in the literature. So how to disseminate it? I mean, in the first place, we are creating a homepage, and then you will see something like the code on the main layer, and by clicking, you can get to these public health messages So, for example, what is smokeless tobacco? What is the benefit of cutting down smoking in the elderly? Or effectiveness of intervention? What is the most effective intervention to stop smoking? And then, of course, still the link to the scientific justification. That, of course, is not so much more meant anymore for the layman, but this is, of course, very important to demonstrate that everything, every statement we make is based on clear scientific evidence. So we have established a number of working groups dealing with the issues. So it's 7 working groups overall, and 6 of them are dealing with the scientific evidence for specific risk factors. So we have a tobacco group, we have a group dealing with physical activity, obesity, nutrition, and alcohol. We have a working group for ultraviolet radiation and ionizing, non-ionizing radiation. We have a working group for environment and chemicals. We have the group of screening and early detection, and we have the group of infections and vaccinations. There's one young woman that you see in every picture. This is our project coordinator, Dr. Espinas, who's also here in the audience if you have questions during the coffee break. And she's making sure that the flea circus of scientists is behaving well and that we all deliver in time. And then you also see some reappearing faces. This is Larry von Casa from the International Agency for Research on Cancer and myself, because we are the 2 co-PIs of the project. And so ex officio member, one of us is member of each of the working groups to make sure that it all goes in a kind of harmonized and structured way. In addition, we have the communication group that I already mentioned. And we have a literature group who's finding the scientific literature for us, and the scientific committee that I already mentioned that is doing the peer review of the code in September this year, actually. So now this is just some work in progress and thoughts and some brainstorming and some questions that we are currently dealing with. And for some of them, I don't have an answer yet. We have to await the outcome of the different working groups, and mammography screening is certainly one of the areas. And, well, the first one here is smoking. And I don't think you're very surprised that smoking remains on the list of recommendations. I mean, it clearly is still the major single cause of cancer. However, there's also a few discussions we are having. This is how to point out the role of passive smoking, make it very clear that this also reduces cancer risk. Other forms of tobacco use in the young people, there's more and more other forms of smoking, of tobacco use that become more and more popular. It's the snuff in Sweden, for example. It's the hookah that becomes very popular in the South European countries. So also the public health messages will explain what the other forms of tobacco use are and which of them are also carcinogenic. And importantly, which interventions can I undertake myself to stop smoking? When it comes to UV and radiation, then again, UV radiation is, of course, the cause of cancer. And in addition to the natural exposure, we will certainly also make a statement about sunbed use. There's a wealth of new data coming up. We have to explain why there's the emphasis on the protection of children and a higher vulnerability to sun exposure. And of course, if we recommend something like avoid too much sun, we have to explain what too much sun really means. And this is not simple in a single sentence because of the also variability of vulnerability. But I've seen the UV index here also on one of the posters. And this is also something that we will introduce in the public health messages. When it comes to radiation, then it's also setting the context straight, because we have the feeling that in such a code against cancer, everybody expects the word radiation to appear somewhere. But there's a little bit of a, let's say, imbalance between the perception in the population and the scientific evidence that when there's, for example, an accident like we had in Fukushima 2 years ago, then the whole of Europe seems to be concerned that due to this radiation exposure, they will develop cancer. While radiation is, of course, an established cause of cancer, but what causes the cancers are actually other exposures to radiation. And I think the most prevalent one here in Europe, this is radon exposure at home and at work. And we have some recommendations now how to identify whether you are exposed to higher levels of radon and what you can do about it. And diagnostic radiation is certainly also an area where it includes some avoidable causes of cancer. So a big working group is on physical activity, obesity, nutrition, and alcohol. And I think one of the very critical discussions, this is really in the alcohol about setting limits. The current version of the code is recommending 2 glasses per day for men, 1 glass for women. And of course, this is revisited, and we are discussing various options. And the important thing is it has to be backed up by the science. What can we really recommend from a scientific point of view? Also that all the recommendations are straight and that we have clear scientific evidence that we can justify our recommendations. Physical activity, here it's also a matter of definition. A lot of people think by physical activity we are talking about marathon, and of course you can't run a marathon every day. So what is really physical activity? And I think it's very important to communicate that even modest physical activity is beneficial for avoiding cancers. We are discussing about the wording, terminology here between healthy body weight compared to obesity, because we got some feedback that obesity was actually very difficult to understand for the layman. So we want to produce a better explanation, phrasing for it. And when it comes to diet, then we have currently a discussion, how do we also balance the encouragement of eating fruit and vegetables versus the discouragement of eating meat, salted food. What do we do about the sugary drinks and the fast food? So environment and occupation, this I think has been described in a relatively cryptic form in the previous version of the code, more or less by saying apply regulations, and this is difficult when people don't really know what the regulations are. So how can we point out that environmental occupational chemicals are causes of cancer, but also do not create a kind of unnecessary fear that everything that surrounds us is causing cancer, because this is also not the message we want to give. So we think that environmental occupation is actually an area where you have to be very explicit of where the real causes of cancer are, and which are probably also urban myths in the population, mentioning only mobile phones as an example. That got a lot of attention over the last years, but if you look at the evidence from cancer research, there's actually very little evidence that it's related to an increased cancer risk. So the perceived environmental risks is also very important, but especially in never smokers, occupational cancers become a major proportion of cancer causes. So it's important to include it in the code and to raise the visibility that contributing to a healthy environment will also lead to a decrease in the cancer burden. Now the working group on infections and vaccinations, they also have a lot of work. Previously, only the vaccination against hepatitis B was part of the code. So there's more vaccinations that are currently under discussion. The most important one, I think, is clearly the HPV, human papillomavirus vaccination. What recommendation can we give here? At the moment, it's not standardized across Europe if you look at the different countries. Other infections, especially other forms of hepatitis, also testing for HIV to determine your cancer risk, testing for Helicobacter pylori. These are important issues that are under discussion to see how to integrate this in the code also to see at which level we can actually implement it. And here there might also be special target groups for these vaccination programs that need to be specifically mentioned. However, overall, there's also the discussion of primary prevention in the whole area of infection, and that is to talk about safer sex, which was not part of the previous version of the code, which of course might be a good recommendation to prevent some of these infections that are related to a higher cancer risk in the very first place. But then you also have to be specific, what do you mean by safer sex, and which are really the interventions that have proven to be successful. So this was a little bit of the, you see, it's all in this kind of blue bubbles at the moment. So we have the working groups that are debating very lively about a lot of issues. I mean, there's some very easy issues we can deal with. I mean, most of the recommendations they had in the previous code will really be confirmed. It's only probably a matter of raising, but there's quite a kind of portfolio of new options that we are currently discussing, and it might be that the new version of the code actually also looks quite different compared to the third edition we have now. So it's all very interesting, and I hope that soon I can tell you the outcome, what the new code is, so that we can put it into practice. So one word about the secondary prevention. The screening group is, of course, also heavily debating. The cervical screening is I think, probably the most clear one. We heard for the breast screening. That's a discussion that really takes a lot of the time of this working group. Also, if there's a recommendation on mammography screening, what is the relevant age group? At the moment, we have different recommendations. If we look at the different European countries, at which age the standardized screening should begin. Colorectal screening is, of course, another one that is already part of the code. But then there's also screening programs that will be evaluated for the code for the very first time. This is for prostate cancer, but this is also the screening with X-rays for lung cancer, and this is the melanoma screening, where there's pilot projects in Germany at the moment. And with all the screening, also there's the discussion of how to integrate early signs of cancer in the code. It was part of the second edition of the European Code Against Cancer, actually, has dropped out from the third edition, and now we are discussing of whether this should go back in the code or how the scientific evidence really looks like. So this brings me to the end. Thank you for your attention. This is hopefully for you a little bit of information what we are going to do and what the new features of the European Code Against Cancer will be. And on this last slide, you just see a few of the key players that are involved in the update of the code. And in addition to our scientific secretariat at IARC, we have the different working group chairs, which is Rolando Herrero for infections, Maria Leon for tobacco, Isabel Romieux for nutrition, Nerio Senyang for screening, and Jane Wardle for the communication group. And thank you very much for your attention.